So getting back to this diagnosis thing, I want to talk a little bit about the DSM, and that's the current, Bible for psychiatric disorders. It's actually produced; they're published by the American Psychiatric Association. So it's psychiatrist-based, medical school kind of based, and it's this thing that for every single disorder that we cover in this class, we're going to go over the DSM criteria. What has to be going on for you to have this disorder? And, for example, for depression, you have to have 5 of 9 symptoms for most of the day, nearly every day, for at least 2 weeks. You need to have low mood, feel guilty or worthless, suicidal thoughts, difficulty concentrating, and you gained weight. I mean, those would be 5 symptoms. There's other ones you can have instead. Switch out with some of those, but then if it's most of the day, nearly every day for at least 2 weeks that you have those things, then congratulations, you have depression. Major depressive disorder, in fact. And I just want to, again, go back to this idea of there's a trajectory of the way people have thought about disorders, and I want to give you a sense of where the DSM fits into that, because you can get the sense that it is the Bible, it's the holy word of psychiatrists or something that has this authority, and it is good. It's the best way for diagnosing these things that I know of. But let's talk about what a diagnosis is and why that is and is not important. Okay, so a diagnosis just means that it's a label that you put on symptoms. So it would be, what I just said. You have these 5 symptoms and, 2 weeks or more. So I can say, oh, this patient I have has major depressive disorder. And you can know just from those few words, oh, God, he's probably really down. It's been at least a couple weeks that he's been feeling this way. It's like all day, most, or at least most of the day, pretty much every day that he's feeling this way. And he has a few other things going on too. You get that sense in just 3 words or so. So it's powerful. It's a powerful way to communicate, especially for doctors between each other. And then for research and for treatment, it's important because I can say, okay, I now have this class of people that have major depressive disorder. They have this label, and then I can look at what people that have that label are like. What sorts of treatments do they respond to? What sorts of things can I do with those people and make that label go away, basically, they don't have that stuff going on anymore. They're not sad most of the day, nearly every day anymore. Well, okay, if I have them exercise three times a week for at least a half an hour, for more than half of them, it makes that thing go away. That's actually true. So that's good to know. And the label helps us to know that stuff, because if we didn't have the label, we would have a hard time doing studies to fix, thing X if we didn't have a common definition of thing X. And that used to be how it was. Like in the early 1900s, you'd have a doctor, at Hospital 1, diagnose someone with schizophrenia, and then take that same patient to Hospital 2, and the doctor would diagnose them with something else. There wasn't a standard definition of any mental disorder, really. What changed that was the DSM. And the DSM-1 actually, and the DSM-2 were basically the same thing. They came out in like the 50s or so, the middle part of the 20th century, 1950s or so. And they were very psychodynamic. So DSM-1 and DSM-2, the first 2 versions of the DSM, they tried to get everyone on the same page, but they messed up. They did something dumb, okay? So they didn't just do what we do now, which is describe, the symptoms and leave it at that. They tried to explain the symptoms in DSM-1 and DSM-2. They really believed in psychoanalysis, and so they said, listen, if you have a patient, and that's what they were interested in. They were interested in the cause. They weren't interested in what it looks like on the outside, because that's a superficial thing. We want to get deeper into the truth of what's going on for this person, get to the cause, and doctors know the cause. And that is great. I mean, I agree. If I knew, it's sort of what we do in other parts of medicine. If someone comes to you and he's like, oh, my leg hurts, and you're like, oh, it's because your bone's broken. So we get to the cause, and then we treat the cause. We say, oh, you need a cast, you need a splint. We can treat the cause. Or some other guy could be like, my leg actually doesn't hurt, but it looks kind of gross. And you look at it and like, good God, man, your tibia and fibia are sticking out of your skin. Your leg is broken, even though it doesn't hurt. You must be in shock. So the symptoms are different. It hurts or it looks gross. but the underlying cause is the same, and so we would treat it the same. We're going to get you a splint, set this thing, and give you a cast. Good God! in both cases, doctors are getting to the cause and so forth, and that's good to fix it. But what psychoanalysis tried to do is apply that to depression. And that turned out to be too arrogant. We don't know what the cause of depression is. We know some things like stress and undergoing difficult life circumstances causes depression, but besides that, certainly in 1950, we didn't know too much. Psychoanalysis thought they knew, but they were wrong. So the DSM-1 and DSM-2 tried to categorize mental illness by cause, and they failed. They burnt, crashed and burnt, because it was the same problem as before. You take them to Dr. 1, take a patient to Dr. 1 in Hospital 1, and he'd be like, this patient has a reaction to the fact that he slept with his mother too long, and that's why he's depressed. And then you take him to another doctor, and they'd come up with some other psychoanalytic reason why the person is the way they are, and they wouldn't diagnose them with depression. They'd diagnose them with some other reaction. They were all reactions to something back then, and you wouldn't have a reliable diagnostic system. Reliable can mean different things, but in this case, I mean inter-rater reliability was poor, meaning rater 1, Dr. 1 would give a different rating than Dr. 2. Okay, so DSM-1 is DSM-2 were good tries, but didn't work out. DSM-3 was a watershed version of the DSM, where they came up with agnosticism regarding cause. Didn't try to talk about cause at all. Just tried to describe what's going on for the patient. What are they experiencing? And we'll give them a label based on that. And lo and behold, doctors can do that. They can ask questions very precisely and characterize what's going on for a patient, and then give them a label, and then we can do great treatment studies and stuff like that, and have a sense of what to expect for this person. Okay, I gave them label X. What can I expect? Well, usually people with label X get better pretty soon. Okay, good to know. I'll be hopeful about this person. Label Y, maybe they usually don't do better unless they get some treatment. Let's get this person some treatment. So that's kind of the idea. And that's where we are right now in terms of our diagnostic system. It's good, it's reliable, but one thing it doesn't do, going back, there was something nice about what those psychoanalytic folks were trying to do, is get to the cause. You're experiencing X, you're experiencing sad mood, and you say, oh, I know why. It's because you're depressed. Well, depression doesn't say why. It's actually just describing the sad mood itself. It's like someone comes into your office and says, I'm sad a lot, and you say, oh, that's because you're sad a lot. That's basically what we're doing. It's not a because thing. It's not really a very good level of explanation, at least in my opinion. It's a good describer, but it's not a good explainer. To explain, we have to look in some other directions, and we'll do that a lot this class. But I kind of wanted to orient you to that in this first module while we're talking about assessment and the DSM and stuff.